A very good afternoon. At the outset, I would like to thank Dr. Ashok Shroff sir for giving me this opportunity to give this talk today. So, my topic is to what are the corneal issues that we encounter in unhappy patients post an uneventful cataract surgery and how we can go about preventing it or treating it. I do not have any financial disclosures. So the causes of unhappy patient in postoperative period can be divided in the immediate postoperative, that is on the day 1 or 2, and in the week 1 or 2, or maybe in the late postoperative phase. So as a cataract surgeon, after an uneventful surgery, what we look for is a clear cornea, an IOL in place, a happy patient, and a 6/6 vision. But the first thing that scares us is to see the corneal edema on postoperative day 1. So most common cause for the corneal edemas in the postoperative day 1 phase is when we operate on hard cataracts like brown cataract or mature cataracts, where we use high phaco energy, more phaco power, or instrumentations are entered into the eye multiple times or endothelial touch happens. The IOP can raise, because of which epithelial edema is seen in the immediate postoperative phase because of retained viscoelastics, retained lens matter, or when we deal with pre-existing corneal conditions, especially Fuchs corneal endothelial dystrophy, where there is corneal gutte and there's chances of corneal edema developing in the postoperative phase. Descemet membrane detachment, which is not noticed on table and we get to know it on the postoperative day 1. When there is wound leak, there is hypotony and presence of DM folds that occurs. Epithelial defect that occurs because of inadequate proper placement of the speculum or while removing it, or overhydration in diabetic patients where the epithelium is loose and we can develop a defect on the postoperative day 1 or 2. And lastly, TAS, that is toxic anterior segment syndrome, because of the inflammation that happens. So when we handle, when we operate on patients with brown cataract or mature cataract, it's very important to do a good pre-op evaluation and a planned approach, so that the patient is well counseled, and even if edema occurs, they know the recovery time for the visual recovery can take some time, and they are mentally prepared for that. So we need to use a dispersive viscoelastic to coat the endothelium. The phaco power and time should be kept in check, and any unnecessary entry or exit of multiple times the instruments inside the eye or endothelial touch should be avoided. And if any edema occurs, we need to treat it with hyperosmotic agents and steroids to control the inflammation. And of course, the newer agents now, that is a ROCK kinase inhibitors like riposodil, plays a very good role for endothelial regeneration. So the raised IOP because of the retained viscoelastics or lens matter can be handled by using IOP lowering agents, topical steroids, and to do an AC wash to remove the cortex or the lens matter. Most common corneal dystrophy, that is the Fuchs corneal endothelial dystrophy, uh, has a very typical beaten metal appearance because of the corneal gutte seen in both the eyes. So we need to do a good preoperative slit lamp evaluation and counsel the patients accordingly. A preoperative specular microscopy helps. If the counts are less than 1500, there is greater chance that you can develop a corneal edema. It can also go into decompensation. As USG pachymetry, if the pachymetry thickness is more than 620 microns, again chances of corneal edema postoperatively is high, so the patient needs to be counseled accordingly. So we need to keep a check of the phaco power and the flow rate. And of course, if edema develops, we need to go for with hyperosmotics and topical steroids. Usually Fuchs not easily missed because of the significant gutte that we see. But sometimes some patients have just minimal gutte or fine gutte which are scattered around. So it's very important to do a good slit lamp examination in all of our patients, taking some time about it. A descemet membrane detachment which is missed in the initial phase can be seen postoperatively. Sometimes if the edema is very high, we can go for anterior segment OCT to know the location and the extent of the DMD, which needs to be managed immediately surgically so that there's better chances of attachment of the descemet membrane and visual recovery is much better. Wound bone which occurs because of the poor wound architecture, we need to address it immediately. Otherwise, it leads to wound leak, hypotony, and DM folds which persists for quite some time. Epithelial defect also needs to be treated accordingly. So predisposing factors mostly for DMD is age. Dense arcus patients who have dense arcus are also prone to develop descemet membrane detachments. If there is a history of DMD in the other eye when operated for cataract, there's more chances that this new fresh eye which you're going to operate again has a chance of DMD. So the site of DMD, at what step it occurs, commonly during the entry or during wound hydration, it is important to intervene as fast as you can, because the earlier the DM gets attached, the better chances that the edema resolves faster and the visual acuity is not affected. So either we can use air or gas, that is 14% C3F8 or SF6. as well as or suture can also be used. So there's an entire protocol that is the HELP protocol based on the height, extent, length, and pupil-based measurements, based on which, whether it is planar or non-planar DMD, we can plan medical or the surgical management of descemet membrane detachment. So the toxic anterior segment syndrome, that is, any inciting agent should be avoided, and usually there's a limbus to limbus corneal edema with sterile hypopyon and a dense fibrinous membrane, which usually presents within the 12 to 48 hours post-operatively, which usually responds very well to topical steroids. It's important to differentiate it from immediate endophthalmitis. So in the week 1 or 2, we can have a DMD which develops little later, or it's missed in the initial phase thinking it's just a corneal edema and we are treating with hyperosmotic agents, and later on once the edema settles down, we are able to see a descemet membrane slightly detached in the periphery. So it can be noticed in the week 1-2 also. Again, the line of management goes according to the HELP protocol. The corneal wound entry, if it becomes very anterior, it can lead to irregular astigmatism, which also causes glare and other dysphotopsias. Corneal epithelial toxicity, because of the multiple topical medications that are used, if they are not used preservative-free or over-medicated, then can lead to punctate epithelial erosions, which also causes patient discomfort. Faint DM folds, which are persisting for a long period of time, and raised intraocular pressure because of the steroid responders. So in those cases, we can use low potent steroids like 1% loteprednol also helps with controlling the inflammation. So the DMD management, according to the HELP protocol, we should go for a good bi or triplanar corneal wound constructions, prefer preservative-free topical medications. Cornea has a good healing capacity, so give time for it to heal. Do not over-medicate the patient unnecessarily, and a good IOP management. In the late postoperative period, we can have the wound scarring because it can lead to higher order abrasions, which can also cause astigmatism. The corneal astigmatism component with the rule against the rule should also be treated in picture. Surgically induced astigmatism should also be consist. And most common problem, that is a foreign body sensation, which persists for almost 4 to 6 weeks post-cataract patients. In most cases, the pre-existing dry eye should be looked into. Any corneal infections that can develop in the later period because of long-term use of topical steroids should also be taken into consideration. So reassurance is the key in most of these cases, a good dry eye management, astigmatism management, and corneal ulcer treatments. So in brief, to conclude, I would like to say that important takeaway points are: approach cases in a conservative manner and treat the cause appropriately. Correlate the visual acuity with the anterior segment appearance. Listen to patients patiently, and maintain an open communication. They're coming to you even after 6/6 vision. That means there's some amount of discomfort that they have. Most of the times, a good reassurance and increased chair time clears all the problems, and they do not go doctor shopping to treat their problems. Yeah. Timely referral to senior colleagues or corneal and retinal surgeons also helps in treating major of the problems and give a good symptomatic relief as well as a good visual acuity. Thank you.
Thank you, Dr.